शेयर करके ना वो ऑन कर दो जो पहली स्लाइड है।
हम्म। अब उसमें चेक, हाँ मैं ही आ रहा हूँ, ठीक है
ये
जबरदस्त।
है। अब अब आपने स्पीकर मोड किया होगा।
हाँ अभी,
मैं सर को यूट्यूब पर लिंक भेज दूँ।
अभी स्पीकर मोड पे हूँ, और स्पीकर मोड में ही ये सब कुछ हो रहा है।
अच्छा जी, निशान भाई,
हाँ जी,
आपकी आपका वीडियो आ रही
अभी आएगी।
है उसको।
मैंने ठीक है। नहीं, यहाँ पे भी कैमरा एडजस्टेड नहीं है, इसका इधर उधर के जा रहा है, ज्यादा नहीं है। ओके।
पहले करेंगे लेफ्ट क्या,
इसी से
हम साइड पे
आप मेरे साथ फिर आपको पढ़ाएंगे अंदर से।
निशान भाई, पहले सिर्फ वेबकैम ऑन करें, आप इधर ही खड़े हैं, स्क्रीन शेयर ना करें, जस्ट वेबकैम ऑन करें। रिकॉर्डिंग ऑन करके पोस्ट टूल्स में देखें रिकॉर्डिंग। ठीक है, जाते हैं लाइव पे, प्रोजेक्टर के ऊपर रिकॉर्ड हो रहा होगा, या फिर वो सर के लैपटॉप से जाके रिकॉर्ड।
वो सारी वीडियो बना ली वीडियो भी कैमरा बना लो।
सारी नहीं बनानी, बस आप क्लिप्स लें।
प्रेजेंटर के थोड़ा सा सबके थोड़े थोड़े।
निशान भाई, रिकॉर्ड कर ली। निशान भाई, मैं स्टार्ट कर रहा हूँ, रिकॉर्ड ऑन कर। चेक 1 2 3, चेक। Bismillahirrahmanirrahim. I welcome you all to our live academic session today. We are going to talk about how to do a safe mastoid surgery, which is a modified radical mastoidectomy. So, first of all, I would like to welcome Professor Naveed Aslam, who has graced the event, and he would be providing us with valuable intel on this topic. So first of all, I would like to invite Dr. Anam Anwar, who is a trainee registrar in our department, and she's going to present on the topic, and then we'll have a question answer session, and we'll ask some important questions related to the topic uh, to Dr. Naveed. Thank you.
Then उसको Assalamu alaikum everyone. I'm Dr. Anna Manwar, ENT resident, Sheikh Zayed Hospital. The topic I'm going to present today is how to do a safe MRM. We'll discuss about surgical anatomy of mastoid bone, surgical anatomy of middle ear, indications of MRM, preoperative audiology, HRCT, steps of MRM, and we'll discuss how tips and tricks how to avoid pitfalls or how to make it safe. Mastoid bone is an air-filled cavity, air-filled bone with mastoid process, mastoid air cells, and superiorly it is bounded by the tegmen tympani, posteriorly by sigmoid sinus, and interiorly by posterior wall of an external auditory canal. This is another picture showing communication of mastoid bone with middle ear cavity. This is mastoid process. Mastoid process, mastoid air cells. It is communicating with attic of the middle ear cavity through editus. This is an unsafe area surgically because the disease lying here is quite difficult to eradicate. And this is the flexible part of temporal bone. We should be more careful while dealing the disease lying in this area. Surgical anatomy of middle ear. Middle ear is bounded by 6 boundaries. Superiorly, it is bounded by tegmen tympani, laterally by tympanic membrane, and medially by cochlear promontory, oval window, round window, facial canal. The important structure lies within the oval cavity is ossicular chain. Disruption
In the beginning.
स्टार्ट से कर लेते निशान स्टार्ट से कर आप यूट्यूब पे आ रहा है प्लीज के बाद आपने कहा वो यूट्यूब थोड़ा स्लो चलता है ना आप करें बिस्मिल्लाह करें शुरू से शुरू करें
Zishan, it's not working.
प्रोफेशन
जी ठीक है सर। मैं किसका पढ़ रही हूँ?
मेरे ना इंटरव्यू दिया था प्रेजेंटर
उधर तो नहीं आ रहा।
प्रेजेंटर भी ऑफ कर ठीक है
नहीं, देखो नहीं आ रहा।
यूट्यूब पे आ रहा है यूट्यूब पे
नोट्स डालती हूँ। Is a preoperative otoscopy with the erosion on the head of nucleus and incus. Mass is in contact with the stapes and the rest of the tympanic membrane is seen subtracted. The next is preoperative audiology. Before going into the audiology, we will discuss the mechanism of conductive hearing loss and sensory neural hearing loss in the patient of cholesteatoma. There are two ways due to which hearing loss occurs in the patient of cholesteatoma. The first is release of osteolytic enzymes that cause erosion of the ossicles. As the disease progresses, the erosion of ossicles continues and the eroded part of the ossicles keeps adding up into the cholesteatoma cell. Now, the sensory neural hearing loss is relatively rare in the patient of cholesteatoma, but it can occur in the long process of disease due to topical systemic antibiotics that are prescribed to patients to treat chronic suppurative otitis media and toxins that are released from the positive agents in CSO. This is the preoperative audiology of the patient who underwent MRM in our setting. He was having the right sided conductive hearing loss. The left side was quite normal. The next and the troubleshooting area while doing MRM is right is HRCT temporal. Certain landmarks that need to be visualized pre-operatively on CT scan. Regarding this, we are lacking a software called ICOM. If we have this in hand, operating surgeon must be used in every case to read every scan in sequences prior to surgery. But the conventional setups lack this system because of certain sections might be missing on the films that we retrieve from radiology department. आगे मैं पीछे नहीं, मैं आगे जा रही हूँ। नहीं मैं ये नहीं हो सकता, मुझे पीछे जाना है। सेक्शंस मिस हो जाएंगे।
आगे जाना है।
मैंने एक स्लाइड आगे अभी नहीं जाना, मैंने अभी पीछे नहीं, एक स्लाइड।
Skip that.
चलो ठीक है, ओके। द एच in HRCT temporal, the checklist or the surgical landmarks we must see before going for MRM is scutum, ocular chain, extent of disease, jugular bulb, sigmoid sinus, and its relation to mastoid cavity, tegment tympani, and the mastoid pneumatization and ventilation of the mastoid air cells and middle ear cavity. This is a picture of the CT scan, which is showing the ice cream cone appearance of the ossicular chain, which is quite normal. This is the normal appearance of the ossicular chain on HRCT. Mastoid air-filled cavity or the well-pneumatized mastoid air cells can also be seen in this section. This is ossicular chain. Below this is brucic space and above is epitympanic recess. This is the level of the tegment tympani, and this is normal, but this erosion occur in the case of cholesteatoma. This is another CT showing posterior wall of the middle ear, where facial recess and a tendon of stapedius, that is pyramid facial recess, and sinus tympani is seen. This is important because sinus tympani is three different types, can be shallow or deep with posterior or lateral link to facial canal, facial nerve. Mastoid air cells are well pneumatized. If the disease lying in this area and the section is missed, this can be quite problematic later on while doing MRM. We have discussed the normal CT scan and the landmarks. This is HRCT temporal bone of the patient was having cholesteatoma. This is endoscopic picture, the mass lying in the middle ear cavity. Here we can see the blunting of the scutum, thinning of tegment tympani, and canal, later semicircular canal erosion is seen. This is our mass lying here, blunting of scutum, thinning of tegment tympani, and later semicircular canal erosion present here. This is another patient of CT scan of another patient was having cholesteatoma. We will compare it with the contralateral ear. As we can see, the ear cavity is well pneumatized on the contralateral side, but it is occupied by cholesteatoma, which is causing blunting of scutum and expansion of the epitympanic recess and procex space. Now, as far as the pneumatization of the mastoid air cells is concerned, again, this is contralateral ear with a well pneumatized and ventilated mastoid air cells, but air cells are sclerosed in the diseased ear. The other thing we need to see is jugular bulb, position of jugular bulb. This is the normal high riding jugular bulb as compared to the normal side, which is contralateral. Before going for MRM, we must see the position of jugular bulb. That can be disaster during operation. This is a position of sigmoid sinus. We can see that is normal in the contralateral ear, and here we can see the antepost sigmoid sinus. The last city which is showing the middle ear cavity is occupied by cholesteatoma, which is causing erosion of ossicles, but ossicles are normal in the contralateral ear with the ice cream cone appearance. The must-take areas in HRCT is scutum, ossicles, procex space, pneumatization of the middle ear cavity and mastoid air cells, position of sigmoid sinus, facial canal, and jugular bulb. After HRCT, the next section and the next step we do is consent. We used to counsel people regarding hearing loss till last year, but this is an updated form of consent of our department. Now we tell patient that we'll try to eradicate the disease and we'll try to improve the hearing as much as possible. The consent must be taken and must be verbally told to patient, and written documentation should be done in the language that is understandable to patient. After consent, intraoperatively our goal is cholesteatoma clearance from procex space, editus, antrum, middle ear cavity, sinus tympani, facial recess, and oval window. While doing the clearance of the cholesteatoma, if we do skeletonization of the tegment wall, tip cells, sinodural angle, later semicircular canal, and process cochleariformis, This will further add beauty to your procedure. This is an intraoperative video of the patient whose MRM was done previously in our department. Our goal was to make the cavity disease-free. In this section, we can see the videography that middle ear cavity is freed of disease and the certain landmarks such as oval window, which is free of disease, and the head of malleus and stapes are seen in this. The inflamed tissue is eradicated. Now the cavity is almost disease-free. In the next, we'll discuss about the reconstruction of the hearing mechanism, which is second goal of MRM. This is a piece of conical cartilage that is taken and being harvested. After this, we are doing stripping of the conical cartilage and making a hole in the center of it. We are going to place this for the ossicular reconstruction later on. This is another intraoperative video where we are placing the graft that was harvested over the stapes. The purpose of this is reconstruction of the hearing mechanism that was compromised due to the cholesteatoma, due to the erosion of the ossicles during the disease process of cholesteatoma. After harvesting the cartilage graft, we are going to cover it with temporalis fascia. A 4 into 4 centimeter almost piece of temporalis fascia was taken initially, and it was air dried. Then later on, strips of that temporalis fascia were made, and this is used to cover the mastoid cavity later on after reconstruction. This is video of another patient whose malleus, incus, and stapes were eroded, and all the ossicular chain was removed, and the total ossicular placement prosthesis was placed in this patient. After placing the prosthesis, we are going to cover it with temporalis fascia. Another important step doing MRM is meatoplasty. In the conical bowl, horizontal incision is made and the piece of cartilage is taken out. After that, posteriorly, the skin is sutured in the two sutures, so that the purpose of taking the conical cartilage out is to make the external auditory meatus a bit larger. That might lower the rate of reoccurrence in case of cholesteatoma. This is post-operative video in which we can see the disease is clear. Ossicular reconstruction was done and tympanoplastic graft was placed. The ear is now disease-free. There is no debris or discharge was seen on the post-operative follow-up. Okay, this is a post-op follow-up audiogram that was done. This is preoperative and post-operative audiogram that was done on the same patient. He was having right-sided conductive hearing loss that was reconstructed, and this was later on. After 3 months, the audiogram shows that the hearing is improved to larger extent. This is another follow-up patient presenting in OPD after MRM. As we can see, the middle ear cavity is disease-free. There is no debris or discharge. The tympanoplastic graft is settled. The patient we just look in. Sorry. Okay, what is the key consideration point while doing MRM? The use of the long drilling strokes in a direction parallel to the important structures such as facial nerve, tegment tympani, and sigmoid sinus is important as it facilitates the identification of the vital structures and minimizes injury to them. Important structures should be positively identified rather than relying on the avoidance to the injury. Constant irrigation prevents bone dust from obscuring the underlying structures and prevents thermal injury, particularly to that of facial nerve. So constant irrigation and suctioning irrigation is appreciated in while doing MRM. Removal of mastoid tip cells, lowering the facial ridge, removal of air cells at the sinodural angle, and adequate meatoplasty can prevent the need for revision surgery in canal wall down procedures. When performing canal wall down procedure, the canal wall should be left intact till all the landmarks have been identified. The last section is about tips and tricks if the problematic encounters happen during MRM. The first thing we need to do is to eradicate the area from the hidden areas of disease. That is sinus tympani, sinodural angle retrofacial area, perilabyrinthine cells, hypotympano mastoid tip cells, and retromastoid area. If disease is present preoperatively, first of all, we need to go through all sections of the CT scans. If the disease is present in the hidden area, the tip is to clear the disease from the hidden area is to follow the disease process, and identification of the relevant landmark will help us to eradicate the disease completely. The problematic encounters we might face while doing the procedure is dural injury, dehiscent facial canal, oval window disease, lateral semicircular canal fistula, inadequate metaplasty, CSF leak, and CSF leak or encephalocele or facial nerve injury. If the disease is on oval window, what to do? The dissection of the oval window disease must be started after the gentle palpation. If the disease is lying on the stapes foot plate, it must be gently palpated before lifting the disease from the foot plate. Peeling of the crura in the medial to lateral and posterior to interior direction should be performed. If this proves to be difficult, then continuous dissection may lead to extraction and subluxation of stapes that can later on appear as vertigo or sensorineural hearing loss. While lifting the disease of the stapes foot plate in the oval window disease, pyramidal process is the best landmark. In difficult cases, it is recommended to leave the matrix attached to the foot plate of stapes. The next difficult thing we can encounter is sinus tympani disease. Sinus tympani is bounded superiorly and inferior by the bony ridge, ponticulum and subiculum respectively, and laterally by fallopian canal or facial nerve. It is often not possible to fully inspect the disease, and we can leave the residual disease in this area. But we can avoid this if we keep the sac intact and to ensure its complete removal. The next challenge is surgical access to sinus tympani due to the presence of facial nerve. In case of very deep sinus tympani, retrofacial approach has been proposed. This is mastectomy. This is the intraoperative picture of the mastectomy with a facial recess approach. This exposes the posterior limit of the sac. This is another picture which is showing after dissecting the dissecting the sac from the sinus tympani, a mirror or angled endoscope is used to confirm that there is no residual disease left. The next thing is dehiscent facial canal. The incidence is almost around 15%. It becomes higher in the patient of cholesteatoma, and dehiscence is common on the inferior aspect. If there is a dehiscent facial canal, we can approach the nerve from the superior to inferior when we need to stay on the lateral aspect. In dehiscent canal, intraoperative nerve stimulation and monitoring while dissecting the disease of the matrix of bare nerve is recommended. Another thing we can see, although the lateral semicircular canal fistula can be diagnosed preoperatively, and the patient usually presents with vertigo, and on CT scan, lateral semicircular canal fistula can be ruled out. But if it goes undetected preoperatively and encountered during surgery, aggressive manipulation over the fistula should be avoided. While in the management is in two ways. The classic teaching tells us that canal wall down procedure, we need to continue the canal wall down procedure and we can leave a matrix over the fistula. But the major rationale suggests that we need to clear the disease and cover the fistula with fascia, cartilage, or bone. The second technique is considered superior because it brings low risk of recurrence and preserve hearing as well. And another thing which caused the failure of the MRM is inadequate meatoplasty. It is probably the most common reason for difficulties in canal wall down procedures. A large meatoplasty should be created, and it should be kept stented for at least 10 days post-operatively. Last but not the least is CSF leak and encephalocele. Inadvertent injury to tegment and underlying dura may result in CSF leak or encephalocele, or it can cause both. The management depend upon the type and the size of the CSF leak. If this is a simple dural exposure with no leakage, no treatment is recommended. If dural injury with CSF leak occurs, then depending on the size of leak, if leak is small, we should need to close it spontaneously. But if there is a large leak, we will later on repair it with facial graft. If after management still CSF leak continues, we need to place lumbar drain, bed rest, and prophylactic antibiotics and acetozolamides are recommended to these patients. This is a research article that was performed in 2012, the cause of failure of MRM. In this, the commonest complaint was, it was a research article, it was retrospective analysis that identifies the causes of failure of MRM. The commonest cause was inadequate metaplasty and the disease left in the tip cells. The take-home message from this session is that the right patient selection, which occurs through preoperative endoscopic examination, hearing assessment, and HRCT temporal bone. And intraoperatively, we must identify the surgical landmarks. Positive identification should be done. This will play the key role in success of MRM. Thank you.
ये लाइट पे लाइट पे ये लाइट पे ऑन कर ये वाले उस पे भी आप आ रहे हैं अच्छा Thank you very much, Dr. Anam. It was a great presentation. Now I would like to call Dr. Sarfaraz Latif, Head of Department, Sheikh Zayed Hospital, Lahore. So I would like to call him to moderate the session for the question and answers related to this presentation. Uh, Please, sir, join us.
Assalamualaikum. First of all, sorry, ये चूंकि हमारा पहला सेशन था तो इसलिए कुछ टेक्निकल इश्यूज थे इंशाल्लाह we will rectify in future. Regarding the mastoid surgery, it is a difficult surgery. So I am doing mastoid surgery for the last 15 years, and every year I feel that I have rectified some deficiencies as compared to the last year. So, okay. So my question is from Professor Naveed Aslam sir. He is doing, mashallah, very successful mastoid surgery, and we are all his students. Sir, what is your learning curve? Still, my learning curve is still a ascending learning curve. So, what is your learning curve? Is it's a high static up, or what is your
Perhaps what mastoid surgery as ENT surgeons should be mastoid surgery? The answer is yes, must try. Second question, is it an easy surgery? No, it's not an easy surgery. It's a very I've been involved in this for almost 30 years, and I still think I'm learning. I don't know where is the end to this learning. If you answer your question, it says a long learning curve, and people must understand that the first attempt is the best attempt.
Right.
Get it right, and we must spend every effort and trick get it right for the first. So all those people who temple bone dissections, see other people doing surgeries who make it look easy to you, should not be mistaken that this is a very difficult surgery. अब इसकी जो है, how do we, in my experience, I think it needs a lot of understanding of disease, anatomy, surgical anatomy, and planning. So I think it's a question of how do we make it successful. It starts from preoperative preparation and planning. Every surgery is a different surgery.
Right.
Abhi tak, I think it's not a standard tonsillectomy type procedure. So every surgery is a different surgery. So preoperative planning starts from history, examination, endoscopy examination, microscopy examination. Conventionally, the CT scans were not done. जब मैंने सीखा in England where I made this, conventional teaching used to be that if you have identified the glioblastoma, you don't need to do any radiology. But I think it is essential to do radiology. The reason being your choice of surgery, your approach, how big the cavity should be. I think it is essential that every patient who has a glioblastoma should have a CT scan.
Right.
And we should be able to read the CT scans ourselves. And for beginners, I think one good trick is that initially you should sit with the radiologist and study the scans together.
Right.
Because they know the radiological aspects, we know the anatomical aspects. So I think it's a long learning curve. Abhi aap next questions karenge to
Haan ji, sir. Yes, sir. Sir, as we all know that the patient has glioblastoma, he present with scanty false felt discharge. So, what do you think, or is the patient can present with atypical symptoms?
They can present with atypical symptoms where you don't see many findings on examination. You may just see an attic retraction pocket or a perforation or some kind of osteitis posterior-superiorly. Like in the history, the sequence of events over the years, and then CT scan would help you to reach your final diagnosis.
Right, sir. Sir, this question is on the behalf of our residents. In the exam, there is a diagnosis very clear, patient has posterior superior perforation. And but the examiner is asking, what is your DD? So as an examiner, so what do you expect from the student? What he should tell the DD? Because the diagnosis is obvious. There is a posterior superior cholesteatoma or retraction or some history is giving clue that patient has anticoagulated disease. So what should be the answer of this question?
From examiners, it can be a trick question.
Right.
If you see superior retraction pocket with keratin and classical cholesteatoma, then I think one should avoid giving differential diagnosis.
Right.
Because that means that you're not confident in your diagnosis. However, if you have a posterior, let's say marginal perforation, a discharging ear, not really a classical cholesteatoma, although the symptoms are suggestive of, then you can consider other things like tuberculosis and other non-granulomatous otitis media and things like that. But if it's a classical cholesteatoma, I mean, I would be reluctant to give any other diagnosis.
Okay, but the candidate can tell, yes, the second option may be granulomatous.
But I think, again, if you see a cholesteatoma, granulomatous does not appear as cholesteatoma.
Right.
So that goes against you.
Right.
If there's a classical cholesteatoma sitting there, which you can see, and you include something else in differential diagnosis, that in my opinion, it goes to your discredit
Right.
as a student.
Right, sir. Sir, suppose a patient came to you giving classical history of antequintal disease. So, what is your list of? So, you have told that you will do the PTA examination under microscope. So, these days, majority of our ENT doctors they do the naso 0 degree scope and examine the tympanic brain or auditory canal. What do you think? Which one is superior, EUM or nasoendoscopic
If you have
telescope?
if they have the facility, I think microscopic examination is very useful. But if it's an outpatient and you don't have the facility of microscope everywhere, but I think using an endoscope can be very important.
Right.
Because you can't have microscope everywhere. Not everybody has microscope in OPD settings.
Yes.
The advantage of microscope is that you can gently do section cleaning.
Yeah.
You can look into the corners, which you can't do easily with the endoscope. The advantage with the endoscopy, you can do it anywhere.
Yeah, of course. So I think this is a good choice that the examination microscope has extra advantage. Sometimes
Extra
there is
advantage. You
there
can
is a crusting in the posterior
crusting, you can
superior.
remove the crusting, do
Yes.
the suction, you can actually suck out the contents, and you can also it gives you two-handed approach. So I think a lot of people are doing endoscopic work, and I think it's a way forward for many otological procedures.
Right.
But there is no alternate to microscope.
Okay. Sir, regarding my question from
आपकी
CT scan.
आवाज नहीं आ रही.
It was. Sir, regarding my question regarding the CT scan. Obviously, no, and recently we attended the Autocon and they stressed that if the diagnosis is a clusteroma, you do the MRI. So what do you think? Which one is superior, CT or MRI?
I think for students as well as for all of us, the investigation of choice is a CT scan.
Right.
HRCT is the investigation that we need to do for cholestoma evaluation and surgical planning. The role of MRI is in a different situation. Role of MRI, diffusion weighted images come into play if you've done a canal wall up procedure or if you've done mastectomy with cavity obliteration, where you cannot examine the cavity for possible recurrence of cholestoma. So in those situations, if you want to follow them up, instead of doing what used to be a second look operation, you can do diffusion weighted MRI.
Right.
But for surgical planning, MRI is not the treatment of choice.
Right.
The MRI is only used in certain situations, like if you suspect recurrence and there are a lot of granulations and the cavity is full, you don't know whether it's cholestoma or something else. For hidden areas, you can use MRI in revision cases. But primary investigation for, I think, is a standard HRCT.
So I am adding few points that if you are operating surgeon, CT scan is extremely helpful, and it is very difficult to take bony information from the MRI. So if you are planning for surgery, the good choice is CT scan. Sir, regarding the consent, so we are interested to know how you counsel your patients that you are planning to do the modified radical mastectomy, how you consent, take the consent from the patient.
I think it's an ignored area, and I think it's a balance that you have to achieve because this surgery has potentially a lot of serious complications.
Right.
The possible complications of facial nerve damage, dead ear, damage to the dura and CSF leak. These labyrinthitis, these are serious complications. So if you tell that patient that the possibility of all these things, then I think a lot of patients would choose not to have the surgery.
Right.
So therefore, your counseling has to be a very informed counseling. You have to give them some statistical data that this is the possibility of facial nerve damage, whether it's going to be, most likely it's going to be temporary, it recovers if it happens. Similarly, the risk of dead ear, whatever it is, 1% or whatever, that's an experience set. But at the same time, you also have to tell them that the cholesteatoma in itself is likely to give you more damage and complications if you don't get it done. It's just like counseling a patient for laryngitis. Although it may look very, very grave to the patient that this can happen and this can happen, but you have to tell them the other side. And in informed consent, I think we must give them some data, some percentages that this is the possibility of two, three things I think we must list in consent form. The facial risk of facial nerve. But the only trouble is that the statistic data that you available comes from very experienced centers.
Sir.
So if you're talking about guy who's an experienced otologist says the risk is 1%, and then you are a beginner,
Yes, sir.
you give that statistical risk. So I think you have to be honest with that patient, that you tell them that. But I think everybody should make an effort not to have these complications.
So my next question is, in the different departments have different protocols. Some do from the post-aurical approach, others do the end-aurical. So what you suggest for the beginners who are starting the mastoid surgery is start post-aurical or end-aurical? We know that both approaches have different indications.
Yes.
So which one is safe for beginners?
I think one message is that you should learn both.
Right.
But which patient should have an end-aurical, patient should have a post-oral approach, would depend on your training and your trainer and your mentor, as well as the indication. I think there is an emphasis now that one should have small cavities.
Right.
Either primarily you should do a mastectomy with a small cavity, or we should obliterate cavity in a way that it's not a big cavity, which is a discharging cavity. For beginners' point of view, I think a safer approach is a post-oral approach, because it gives you a good exposure. You can expose the mastoid, and you can do almost everything with the post-oral approach.
Right.
However, in certain situations, end-oral is difficult approach to learn. I've taught you guys, but that's not something which is taught everywhere. But in certain situations, like if you're dealing with an anticholecystoma, it's a sclerotic mastoid, and if you want to approach from anterior to posterior approach, then end-oral is the approach of choice. Therefore, this is why I said the diagnosis of cholesteatoma is not enough. You need to know the extent of the disease. You need to know the pneumatization of the mastoid. You need to know the exact nature of ossicles, involvement, any involvement of the tegment. So all these put together, I use all that information to decide before surgery whether I'm going to use end-oral or post-oral, anterior to posterior or posterior to anterior.
Right.
And this is where I think we should learn both, because every patient would require a different approach.
Right.
But if you ask me which one is the easier, I think one should start with post-oral.
Right. Because in the post-oral approach, if initially you are doing the cortical mastectomy, you may identify the lateral canal,
Yes.
and that is very important landmark to proceed further.
Because in post-oral, your angle is different.
Yes.
So if you're doing mastectomy with an end-oral,
Yeah.
I think as a beginner you may struggle with those things.
Right.
Because to maintain the ear canal and do mastectomy in experienced hands, you can do that. But post-oral, I think, is something where one should familiarize with all the structures and the landmarks.
Sir, my next question is regarding the facial nerve. This is the single most important fear to the operating surgeon. So, what is your advice? How we must identify the facial nerve? Either we identify its landmark first, or first facial nerve confirm it with the landmarks. So, what should be the approach?
I think it's facial nerve is, you want to see it first,
Right.
but you're likely to see it last.
Right.
Because the disease is such that it usually covers that area. And I think the best thing is not to go for it first. First, do a mastectomy, identify sigmoid sinus, clearly identify the lateral semicircular canal. If there is one most important landmark in mastoid surgery, I think it's the lateral semicircular canal.
Right.
It can lead you to anywhere. It will tell you where the facial nerve is. It tell you the relationship with the ossicles. So if you identify that, what I usually suggest is that you clear the disease from all other areas and then come into the area of the facial nerve. One should know the anatomical relationship of facial nerve with the lateral semicircular canal. And what I usually teach is that remove the cholesteatoma from the mastoid, clear it. Know where your facial nerve is, take the bridge down, and then start peeling off cholesteatoma from superior to inferior. As you peel it off from superior to inferior in the attic, automatically your facial nerve comes.
Right.
If you try to look for facial nerve first, it's impossible. So very gently with a cotton plaited or with a frying pan or whatever. Once you've cleared the attic, try to peel the fascia, the matrix of the cholesteatoma down into the middle ear. Facial nerve is the first thing which uncovers.
Right. Okay. Sir, sometimes there is extensive granulations in the facial nerve region, and there is a bleeding, and the incus is absent. This is a difficult situation. So, in our last best try, it was very difficult best try. So there was no ossicle, it was only granulations, and there was no bony covering.
Was it cholesteatoma?
Yeah, it was cholesteatoma. So give some tip how to handle this situation.
I think granulations are more difficult than cholesteatoma itself.
Right.
Which means it's an osteitis, and if it's involving the facial canal, then it's going to be difficult to peel it off. One of the objectives in modified radical is that we want to clear the disease, and we want to reconstruct the cavity.
Right.
With a graft like you've shown in the tympanic cavity as well as the mastoid cavity. But that is one situation where if you're not sure that you've cleared the disease completely, then I think one would be reluctant to reconstruct.
Right.
Similarly, removing granulations, tough granulations from the facial nerve can be very difficult. If you remove the cholesteatoma and the matrix, and you're not sure about the granulations, at times it is safer to leave it there. I use very fine cotton wool balls, and you just gently scrape off.
Right.
Not with the instrument, not with the needle, not with the frying pan. You just use cotton wool, just scrape it off the facial nerve if possible. As long as you don't damage the facial nerve bundle, you're not going to have facial nerve paralysis. And if you're really struggling, I think you remove as much as you can. Perhaps I would not graft that ear, and I would leave it.
Right. So the next difficult situation, if the cholesteatoma is in the around the or in the oval window, because to handle the stapes in this situation is quite difficult, because when we handle the stapes in staple surgery, it is a fixation of the foot plate. But in this situation, the stapes is a very fragile. So how you handle this difficulty?
With a lot of care.
With a lot of care.
Absolutely. I think, as I said, the most difficult area you should leave till the end.
Right.
Do everything else. Do mastectomy, canal wall down, expose the facial nerve, divide the processus cochleariformis tendon, clear the mid-layer space, and leave this bit till the end. Then I generally use a very fine suction, and you can't use cotton flagellates in that situation. So you need to have fine curved needle and very gently peel off the sac from the foot plate. I think we're talking about a situation where it's no superstructure.
Yeah.
Try to peel it, but you have to be extremely gentle. If you think you're likely to cause a lot of movement of the foot plate, Some people advise you can leave the matrix there and don't graft the cavity. I usually try to remove the glioblastoma from that area. In case you dislodge the foot plate, you should put a little graft on it and plug it with a little bit of fat.
Right.
But if you remove the foot plate, at least you showed you've removed it. But it's something which has to be avoided.
Right, sir. So my next question is, uh, sir, while removing the disease from the tip cells, so we have concept in our mind that the facial nerve becomes superficial here. So what should be the proper landmark that we must avoid the injury to the facial nerve when removing the disease from the tip cells?
I think the landmark, there is a sagittal plane. As I said earlier, that the lateral semicircular canal is the most important landmark.
Right.
So the vertical part runs in a sagittal plane, which is deeper to the lateral semicircular canal. So I think it is always better to start drilling from the top,
Right,
from the lateral semicircular canal, and then drill it all the way down and make it a flat kind of bed, what we call it.
right, sir.
And drilling without that into the tip is not a safe thing. And if you are experienced and if you can identify the gastric ridge, that's a good landmark. But a lot of times it's not there as we see in the books. So I think the best thing is that starting from the lateral semicircular canal, as long as you know that in a sagittal plane you are superficial to that, you're safer.
Right.
You can drill all the way down to the tip. If there's a ridge, you can drill that. But you have to be comfortable with that.
Right, sir. No, sir. The another tricky region is the sinus tempi, and most of the time we are not sure because it is a quite hidden area. You are working behind the sinus tempi. So what you do? You thin the metal wall, or you use any endoscope to see that area. What you do? What is your
I think that's again the area where you should leave it till the end.
right, sir?
Take the facial ridge down as much as possible. Change the angle of your microscope and the patient. If you're doing post-oral, you have to turn the patient head towards you so that you can look into that typical corner. Once you have identified the facial nerve, the oval window, you can actually drill down the pyramidal process. The pyramidal process is the thing which is between you and
Yes,
the
sir.
sinus
Sinus
tympani.
tempi.
So you can easily drill it down because if you can see the facial nerve going down, the second turn and all that, you can drill down the pyramidal process and have access into it. Traditionally, people used to use these mirrors because that was the time we didn't have endoscope. It's an excellent idea to use endoscope in this
Endoscope.
situation. So I think using endoscope as an adjunct to your ear surgery can be extremely useful in these situations. All hidden corners you can look around with an endoscope and clear the disease at the direct.
Right, sir. Endoscope means 30-degree
30
endoscope.
degrees.
30-degree
Right.
endoscope. Right, sir.
Even 0 degree gives you wider angle.
Yes, sir.
Even if you use 0 degree, it'll take you into the sinus. But 30 degrees would be better.
Regarding the Meatoplasty, sir, this is a very important step in mastoid surgery. So, like if you are not sure that you have removed the 100% disease, the Meatoplasty cover later on. So, what is your So what is your tip
Essential.
to make a good Meatoplasty?
Because tip is when you're finishing your surgery, just tell yourself that you need another half an hour.
Right.
Because that is where everybody's tired. You are tired and you want to get away and put the pack in and go away. I do not do any Meatoplasty, and this is what I've taught you guys. It's an essential part, and you can't do a
Right.
mastoid without Meatoplasty. And the other message for beginners is that allow yourself enough time. I don't know how long you take to do mastoid. I still allow myself about 3 to 4 hours.
Right.
Because that's where your time comes in. If you plan it for 2 hours, you have to say get away with method is not essential.
Right. So there is also an online question that what are the disadvantage of white Meatoplasty Meatoplasty.
I think the disadvantage of wide meatoplasty is aesthetic.
Right.
Some people complain, especially girls, and this is making small cavities, doing an end oil incision, and using a front to back approach in patients where there's a small placidoma, you can have a small cavity. And then you can get with smaller meatoplasty. So the
Right.
meatoplasty is proportionate to the size of your mastoid cavity that you create.
Right. So do you do post-operative audiograms in these patients?
For 3 months.
About 3 months. Okay. So my next question is, sir, what is your follow-up routine?
I after surgery, I leave the packs in for about 2.5 weeks. They pack. After I remove the pack, I see them after 2 weeks. After 2 weeks, I see them at 3 months. And after that, usually about 4 to 6 months.
4 to 6 months. Okay. So what is the long-term follow-up?
I think patients keep coming for years and years.
For years. So my second last question is, sir, suppose if we do the MRM and after 6 months patient came with discharging cavity. So what you do? What is your planning
Is
to
your
reassess?
patient or somebody else's patient?
Any patients. So he had MRM.
Yes.
So he has
So I
discharging
think you have
cavity.
to very meticulously clean the cavity
Right.
and make an evaluation. Is it just a discharging cavity? If it's just a discharging cavity and there is no cholesteatoma, then you can manage it in meticulous cleaning. I use silver nitrate to cauterize the granulations in the cavity, and you can do 2-3 sittings after week 10 days interval. If it's no recurrent cholesteatoma, you can get good results.
Right.
But if you see there is a recurrent cholesteatoma somewhere, you have to go back and revise.
Right. From residents, we have very good opportunity. क्योंकि ये launch, yes, Shazin?
I would like to ask, when should we avoid to graft the cavity? Which cases is grafting the cavity not as advised?
I think wherever you think you have doubt that you have not cleared the disease completely, sometimes you come across very extensive cholesteatomas, which is going into different corners and oval window, sinus tympani, anterior attic. Despite all your surgical skills, you are not confident that you have completely removed the disease, then I think it's advisable not to graft. Number one. Number two, in pediatric populations, the cholesteatomas can be very aggressive. And I've had 2-3 in my practice where I had to revise them after about 1 or 2 years because they comes out somewhere else, despite good mastoid surgery in the first place. So when I revise them, I usually don't grab them.
Right.
Because I still have that fear that it will come up.
Right. Thank you very much, sir. It was great session. Dr. Zia, if you want to ask or to add something, Sir Khalid Sahab is here.
इनको पूछने दें
हाँ जी
जिसका खालिद साहब अपना experience
जी sir.
From my experience, I feel myself as still a beginner.
Right.
And the learning curve is all the time. Every time I operate, I feel I had to spend more time. Initially, when we talk about spending time, that's right. You should have a good breakfast, and you should have nothing after. So you are really comfortable mentally and physically. Then you start. My experience was most of the time microscope, so I'm comfortable. Technically, I think the research explained everything.
Right. Thank you very much, sir.
तो एक सबके लिए है
Sir.
mastoid surgery में जो कुछ भी आपने करना है, try to do it first.
Right.
ठीक है, osteoplasty, hearing reconstructions, आपका भी experience होगा to revise that and do that in the cavity is a lot more difficult. इसीलिए आपका जो aim है is complete clearance of the disease. जब मैंने यहाँ पे mastoid करने शुरू किए थे तो general practice was to do radical mastectomy. I'm talking about 25 years ago.
Right.
And I've seen people removing everything, tympanic membrane, ossicles, and remove everything and put a pack and then you go. मेरे ख्याल में आपको नहीं करना चाहिए किसी को. Every bit of tympanic membrane that you can save, you should save. Every ossicle that you can save, you should save. And try to reconstruct this मैंने आपको बताया top, pop, cartilage, incus, transposition. Time लगता है. So you must try to do it for the first time. That's the best time to get your hearing reconstruction practice. Because when you try and do it as a second stage, these are all cavities, adherent हो जाती हैं सारा कुछ. It's very difficult to do those things in second stage.
Thank you very much, sir. I'm extremely thankful, sir, that you spared time. And if there is no more question, this is the end of our academic session. Any question? Yes.
So, what is the ideal instructing point?
I think ideal can if you are skilled incus, it's a very good material. The only problem with incus is that you have to make sure that it doesn't have any keratin or keratin on it. हमारे पास भी are sources हमारे restrained होते हैं. We don't have the top and pop. There are a lot of options अगर if you go abroad. But यहाँ पे the top and pop they are available. But whenever you use top and pop, you must always cover it with cartilage because there is a risk of extrusion. If you just put a fascia on the top or pop, invariably it will extrude through it. So whenever we use that, you must cover it with a thin layer of cartilage. Otherwise, I think a lot of people have used incus for decades. You can play around with it and drill it, and it's a beautiful bone to use.
Finished. Thank you very much, everyone. So, Professor Mona is here. Thank you very much, madam, and welcome. मैं आपको थोड़ा सा ब्रीफ कर दूं. शेख ज़ैद हॉस्पिटल में जब से हम लास्ट 90s से मैं इधर काम कर रहा हूँ, हमारी एक रवायत ही हम मॉर्निंग मीटिंग, हमारी मॉर्निंग क्लास होती है और ये हमारी लेगसी है डिपार्टमेंट की. जो इसी लेगसी को मैंने आई ट्राइड माय बेस्ट टू शिफ्ट ऑन अ न्यू गियर ब्लेंडेड विद द हेल्प ऑफ सोशल मीडिया. तो हमारी ये थर्ड क्लास थी, क्योंकि ये ऑफिशियल तौर पे हमने पहली क्लास को ऑन लाइव किया था, तो हमने सर नवीद से रिक्वेस्ट की थी कि वो हमें ज्वाइन करें. और इस हमारे एकेडमिक चैनल पे हमें ऑल ओवर द पंजाब, मुल्तान से रहीम यार खान, कराची, पिंडी, पूरे पाकिस्तान से लोग हमें ज्वाइन उन्होंने किया. और ये हमारी ट्वाइस ए वीक हमारी क्लास होगी जो ऑनलाइन जाया करेगी और हम इनवाइटेड फैकल्टी को यहाँ पे इनवाइट किया करेंगे. तो सेकेंडली हमारा आपको बुलाने का मकसद एक तो हमारा एक रेजिडेंट ने लास्ट ऑटोकॉन में पाकिस्तान कंपटीशन था स्पीकाथॉन का, सो ही गॉट सेकंड पोजीशन. और ई पोस्टर में डॉक्टर जईम ने फर्स्ट पोजीशन हासिल की थी. तो उस वक्त उन्होंने अनाउंसमेंट की थी और उन्होंने कहा था कि गिफ्ट हम आपको भेजेंगे, आप अपने इंस्टीट्यूट में इसकी सेरेमनी कीजिएगा. फॉर प्राइज डिस्ट्रीब्यूशन आई रिक्वेस्ट प्रोफेसर मोना, शी इज डीन शेख ज़ैद हॉस्पिटल लाहौर. तो सबसे पहले तो सर अगर कुछ कहना चाहें तो प्लीज आ जाइए.
उधर आ जाओ स्टेज पे.
थैंक यू डॉक्टर सरफराज, बहुत ही अच्छा इनिशिएटिव लिया आपने ऑनलाइन क्लासेस का. इसमें मेरी दो सजेशंस हैं कि एक तो आप इनकी रिकॉर्डिंग्स सेव करें, आपकी एक लाइब्रेरी ऑफ दीज क्लासेस they should be available to the ENT trainees online. And the second suggestion is that invite other surgical specialties and in fact medical specialties also to give them an idea that how you are holding these classes, because it's a very, very good initiative. And in this era of social media and online classes and online workshops, this is a very good addition to that uh, type of teaching.
सबसे पहले डॉक्टर ज़ैन मैडम, इसको ये हमारी ऑल लेक्चर्स अवेलेबल ऑन यूट्यूब, ये रिकॉर्डेड उधर अवेलेबल है, तो जो नहीं अटेंड कर सकेंगे वो उधर से देख लेंगे आप. इट्स सॉर्ट ऑफ लाइब्रेरी. So Mashallah, Zain has won second position in Speakathon. लाइए.
आप भी आ जाओ, इधर ही आ जाओ सर. नवीद सर प्लीज.
एक और प्राइज भी है ना? हाँ जी, एक और प्राइज. Second, there is a NGO Imra. So they announced 50,000 for Dr. Zain. Another prize from Autocom. He got the first position in e-post. I request Professor Mona to present a small gift, bouquet, and shield to Professor Naveed Aslam. ये मेरी तरफ से.
आप सबका शुक्रिया. थैंक यू सरफराज फॉर इनवाइटिंग मी. एंड जहाँ तक मुझे याद पड़ता है, सरफराज 98 में आपने ज्वाइन किया था. तो सरफराज, I think Sal was my trainee, and it's so heartening to see कैसे they're taking it forward. I think it's a good opportunity for all the trainees to be a part of this activity. जो आपको there is one thing you will not get from the books is the tips and tricks from the experience. और experience का मतलब होता है कि लोगों ने धक्के खाए हुए हैं, लोगों ने मुश्किलात में से गुजरे. So what you see in the books tells you the standard thing. ये anatomy है, but that anatomy you won't see in surgeries. That anatomy will be distorted by the disease. Similarly, the anatomy books, pictures जो आपकी हैं वो वैसे ही नजर नहीं आएंगी. वो आपको surgical anatomy is a totally different thing. So my advice to you is कि इन ऑनलाइन क्लासेस को भी आप यूज करें. जो एक्सपीरियंस आपके टीचर्स हैं उनकी सर्जरीज को देखें और बार बार देखें. This is going to go on for years. This is a difficult surgery, but you must learn it. क्योंकि हमारी ENT वालों की this is हमारी responsibility है. Nobody else is going to do it. So online या जितनी भी अपनी innovations हैं इसको यूज कर रहे हैं. But at the same time, there is no shortcut to training programs. सर्जरीज को अटेंड करना, असिस्ट करवाना, भाग दौड़ करना और सर्जन से सवाल पूछने और उनके साथ लर्न करना. सो डू नॉट फाइंड दीज एज ए शॉर्टकट टू इट. इट्स अ ग्रेट अपॉर्चुनिटी. मेरे ख्याल में I'll be available whenever सरफराज साहब would call me कि मैं अपने सालों का जो ख्वारी है अगर उसका एक्सपीरियंस आपके साथ शेयर कर लूं. I think you may benefit from it, and it's wise to learn from others' mistakes. तो हम लोग जब अपनी सक्सेसेस आपसे शेयर करते हैं, आई थिंक हम अपनी difficulties भी share करना चाहते हैं, because that's where you're going to learn from कि ये नहीं करना और ये ऐसे नहीं करना और so it's a great initiative, Surfaz, and I must congratulate you and your team जिन्होंने सारा effort put in किया. And as you said, apologies to all the people who have joined in. It's a first time, and I'm sure in due course of time it will become a regular. So congratulations and good luck. Thank you.
Thanks.